approaches. So better understanding is there's always a hope that, and if we cannot ablate it, we need probably drugs for the atrial cardiomyopathy preceding AF and for atrial fibrillation itself. Just a reminder that atrial remodeling is important for the induction of atrial fibrillation, but atrial remodeling is also a consequence of atrial fibrillation. In fact, the first studies, Maurits Alessi showing with AF begets AF, show that the high frequency abbreviates the action potentials, shortens the wavelength, and promotes atrial fibrillation because you can have more reentrant circuit here and you have a vicious cycle. Later studies showed that the high atrial rate itself could produce fibrosis and have structural remodeling, conduction slowing, and also connection remodeling. This is the interaction between the cardiomyocyte. And in the last years, there's also evidence for importance of inflammatory signaling and a steroid inflammation. And it's important because this is a local inflammatory signaling. This is not a systemic one. What we not well understand is how risk factors in cardiovascular diseases produces the substrate preceding atrial fibrillation and whether this is an early time point where we can intervene. This led to the concept of atrial cardiomyopathy, and atrial cardiomyopathy per definition is every change in the atrium which has a structural and functional consequences in the absence of AF in the first place. And conceptually, you see it here that you go from sinus rhythm and you have AF progression to persistence forms. And the atrial cardiomyopathy is all changes due to risk factors, age, and comorbidities. If there's a threshold in the substrate, you may have the first paroxysmal or even persistent from onset atrial fibrillation. And they produce the same substrate and triggers which modify again and support progression. It is important to say that atrial fibrillation produces atrial remodeling, as I said, but in the right part you see that the progression of the underlying atrial cardiomyopathy is also an important process, because even if you stop atrial fibrillation, this progression of the atrial cardiomyopathy persists, and it should be a target for therapy. And I would just talk a little bit about certain comorbidities like HFrEF and obesity, diabetes, chronic kidney disease, how they could produce atrial fibrillation. For HFrEF, it is well known that there's substantial remodeling in the atria. Here you see regional conduction velocity disturbances. This is a slowing due to low voltage areas. It is interesting that if you take atrial tissue from patients with HFrEF and record action potentials, there is no change in the APD. So there is no shortening or there is no prolongation, although in the clinical setting sometimes you see some prolongation. It is only the case if you have HFrEF and atrial fibrillation as a combination, because the high atrial rate do this. They have molecular indices for atrial ectopy. This is ryanodine receptor dysfunction, which is shown here is the open probability of these channels. And there's also evidence for structural remodeling like fibrosis and apoptosis and others. If you compare the human atrial substrates in patients with HFrEF and, for instance, with persistent atrial fibrillation, and have the atrial ectopy and the reentrant activity determinants, there are many similarities. So patients with HFrEF show similar phenotype before atrial fibrillation. Is in the only differences that in persistent atrial fibrillation you have a shortening of the effective refractory period. This appears not to be the case in patients with HFrEF. But this occurs if these patients develop atrial fibrillation. And you see that also patients with paroxysmal atrial fibrillation show some similarities or show changes before atrial fibrillation develops. Chronic kidney disease is recognized clinically as a risk factor, but the underlying mechanism is not that clear. And in fact, there are only two experimental studies which directly address this. And the one is this one where I participated as well. And it is interesting to see that in this chronic kidney disease model, you have a higher susceptibility to atrial fibrillation. And it is interesting that the whole phenotype, which I'm very sorry, this small place here for the mouse, that you have abbreviation of a ERP, you have left atrial enlargement, atrial fibrosis, but the NLRP3 inflammasome, it is the inflammatory signaling which is driving this signal. And this is shown here that if you have chronic kidney disease in a mouse with an NLRP3 knockout, you completely prevent the phenotype. It appears that a local signaling in the atria via NLRP3 inflammasome is extremely important. And antibody, if you treat the mouse with IL-1 beta antibody, you can stop the arrhythmia, suggesting that we have some tools here because monoclonal antibodies are there, but it has to be applied locally because you can't, you will get issues with the immune system. Obesity is a big topic nowadays because we have drugs which are very effective in reducing body weight. And you know, if you feed mice with high-fat diet, you could a substrate for atrial fibrillation. You shown here, you have high inducibility, and also here is a substrate which involves the NLRP3 inflammasome as well. So this is also inflammatory signaling in the atria, because if you crossbreed these mice with a mouse where you have a knockout of that system, you stop the arrhythmia as well. And the phenotype is pretty much what you see in the patients. You have I'm very sorry with the abbreviation of the APD, you have atrial ectopy, and you have also fibrosis. So that means that even in these obesity-induced atrial cardiomyopathy, inflammatory signaling appears to play an important role. Here's just a summary of data related to diabetes. If you look in the literature, you see that diabetes is always listed as a risk factor for atrial fibrillation. If you carefully look at the studies, you will discover that the risk of AF and other cardiovascular consequences is mostly driven by other comorbidities, and it is less driven by diabetes itself. We do not have a clean studies which really shows that atrial fibrillation is really happening in a pure diabetes patient. It is not driven by obesity, hypertension, or combination of risk factors. What is quite clear from experimental studies, which are summarized here in the review article we just got accepted in cardiovascular research, is that you have, of course, lipotoxicity, neuropathy, left atrial enlargement, hypertrophy. You have inflammatory changes. You have a complex phenotype in the atria if you produce a type 1 or type 2 diabetes animal model. And in both type 1 and type 2, you have clear determinants of atrial ectopy. So they are susceptible to atrial ectopy, and you have a substantial structural remodeling with conduction velocity slowing. Which is interesting is there's an important difference between type 1 and type 2 diabetes, whereas in type 1 diabetes, there's a prolongation of the atrial action potential duration. Type 2 diabetes is associated with a shortening. That means that if you apply class 3 antiarrhythmic drugs, they will be successful maybe by patients with type 2 diabetes, but they will be not successful in patients with type 1 because they have prolonged action potentials. And if you further prolong it, you will probably not stop this arrhythmia. So in that sense, it's also interesting what I found out during that review, and I want to share with you, that clinically 40% of type 1 diabetic patients are considered type 2 in the clinic. So we have a really not a clear differentiation between type 1 and type 2 patients, and there's one important difference in the remodeling which we have to consider. So my conclusions are that reentry and atrial ectopy are key mechanisms of AF promotion and progression, and that comorbidities like HFrEF, chronic kidney disease, diabetes, I did not speak about HFpEF because some of these comorbidities are important. We will probably hear in the next talk. They promote atrial cardiomyopathy by producing the same determinants of atrial ectopy and reentry, which we see with atrial fibrillation itself. And it is important to recognize that atrial cardiomyopathy and atrial fibrillation-induced remodeling are additive, interact for the progression, and stopping AF itself doesn't stop the progression necessarily of underlying atrial cardiomyopathy, and this should be a target in the therapy as well. And atrial inflammatory signaling is a common feature of many atrial cardiomyopathy forms, pointing to the possibility that anti-inflammatory approaches may be feasible and should be probably done in the patient. The only caveat is that this has to be applied locally and not as a systemic approach because of the side effects. Thank you very much for your attention. Happy to take questions.